17-year-old Jesica Santillan had waited years for the heart and lungs that could save her. Surgeons removed her failing organs, implanted the donor pair, and restarted circulation, but only then did the laboratory call. Jesica had type O blood. The new heart and lungs were type A. An elementary compatibility check had been assumed, but never confirmed. Welcome to Diagnosis Glitch.
Names have been changed for privacy.
On the evening of February 6, 2003, a telephone call reached Duke University Hospital. A donor heart had become available. The first potential recipient was not ready for transplant, so the organ procurement coordinator spoke with James Jaggers, the surgeon on call for pediatric heart transplants. Jaggers asked whether the donor's heart and lungs might be available together for a 17-year-old patient named Jesica Santillan. The coordinator checked and called back. The heart-lung block was offered for Jesica. The conversation covered details that mattered: the donor's size, organ function, and cause of death. According to Duke's later review, Jaggers did not recall discussing the donor's blood type. He assumed the organs would not have been released for Jesica if they were incompatible. The assumption survived every step that followed. Jesica was a native of Mexico who had suffered for years from severe cardiomyopathy. Her heart could no longer pump effectively, and the disease had also left her lungs weak. A combined heart-lung transplant was not an elective improvement. It was the path her medical team believed could save her life. Donor organs are scarce, and heart-lung blocks are especially difficult to match. Size matters. Medical urgency matters. Geography and transport time matter. Compatibility matters. On February 7th, bad weather delayed the procurement team as it traveled with the organs. While the team was in transit, Jesica was admitted to Duke's pediatric intensive care unit. The donor organs were examined and judged suitable. The procurement surgeon called Jaggers and was told to bring the heart and lungs back to Duke. At approximately 4:50 that afternoon, the transplant operation began. A heart-lung transplant leaves no easy exit once the irreversible part of the surgery starts. Jesica's own heart and lungs were removed, the donor block was placed inside her chest, surgeons connected the major blood vessels and airway, then blood began flowing through the new organs. At approximately 10 p.m. after implantation, the surgical team received a call from Duke's Clinical Transplant Immunology Laboratory. The organs were incompatible with Jesica's blood type. The donor was type A, Jesica was type O. ABO labels compress an entire immune relationship into one letter. Red blood cells made the system familiar, but solid organs carry the same biological warning in their blood vessel lining. A heart and lungs are filled with donor endothelium. The recipient's blood does not merely pass near that tissue, it moves through thousands of vessels inside it with every beat. For some organ combinations, carefully planned ABO incompatible transplantation is possible under specialized protocols that reduce antibodies before surgery and control them afterward. That was not what happened here. Jesica was not prepared in advance for a known incompatibility. The team discovered it after circulation through the graft had begun. This was not a subtle genetic mismatch discovered by a new test. It was one of the oldest compatibility rules in transfusion and transplant medicine. Type O blood contains antibodies against both A and B antigens. Those antibodies normally circulate without consequence because a type O person's own cells display neither marker, but a type A donor organ carries A antigens throughout the lining of its blood vessels. The moment Jesica's blood entered those vessels, her anti-A bodies could recognize the graft as foreign. Antibodies attached to the vessel lining and activated complement a destructive cascade of immune proteins. Endothelial cells were injured, platelets and clotting factors gathered, tiny vessels within the graft began to clot, blood flow through the transplanted tissue was threatened by the immune response meant to protect her. This is hyperacute rejection. It can begin within minutes or hours because the antibodies already exist. The immune system does not need days to learn what it's seeing. It arrives prepared. Once Duke knew the organs were incompatible, Jesica's team began plasmapheresis and high-dose immunosuppression. Plasmapheresis removes plasma, the liquid portion of blood carrying antibodies, and replaces it with other fluid. Immunosuppressive drugs weaken the immune response. Together, these measures can reduce the attack. They cannot change type A tissue into type O tissue. The hospital immediately told Jesica's family what had happened. Duke notified the United Network for Organ Sharing that she urgently needed another heart and lung pair. The operation that was supposed to end her wait had started a second countdown. For the next 2 days, doctors continued aggressive treatment against rejection. On February 10th, Jesica improved enough to come off mechanical ventilation in the morning. By that afternoon, her lung function had deteriorated. The ventilator was restarted. As her condition worsened, clinicians placed her on extracorporeal membrane oxygenation, or ECMO. ECMO moved her blood outside her body, added oxygen, removed carbon dioxide, and returned it into her circulation. It was a temporary artificial lung and circulatory support system buying time while her team searched for compatible organs. The machine could keep oxygen moving. It could not undo the assumption made before the first operation. The public version of a medical error often looks for the instant when one person made one bad decision. Jessica's case is more disturbing because the error crossed several competent teams. The organ procurement organization knew the donor's blood type. Duke knew Jessica's blood type. The surgeon knew compatibility was essential. The transplant laboratory was capable of identifying the mismatch. The information also crossed organizational boundaries. Carolina Donor Services coordinated the offer. Duke's physicians evaluated and accepted it. A procurement team traveled to another hospital. Duke's transplant laboratory performed compatibility work. The United Network for Organ Sharing maintained the national allocation system. Each organization had a different role, and none of those roles were as inherently unreasonable. Organ transplantation depends on this network because no single hospital can locate, allocate, test, transport, and implant every organ alone. The danger appears at the handoffs. When Jaggers gave the coordinator Jessica's name and the coordinator later offered the organs for her, the offer sounded patient-specific. From the surgeon's side, patient-specific could be heard as patient-compatible. From the procurement side, the conversation may have been an offer that still required the transplant center's own verification. One sentence carried two different operational meanings. The organs continued moving because both sides believed the essential work was being done. The failure was not missing information, it was missing ownership. Each part of the system operated as if another part had completed the final confirmation. The procurement coordinator offered organs after the surgeon named Jesica. The surgeon interpreted the offer as evidence of a match. The team moved forward while laboratory confirmation arrived after the organs had already been implanted. Nothing in the process forced one person to stop and place the two blood types side by side before Jessica's organs were removed. Duke's chief executive later said the event showed a need for more robust internal processes and a clearer understanding of the responsibilities shared with organ procurement organizations. Jaggers described his own role directly. He said he assumed compatibility had been confirmed. That's the sentence around which the entire tragedy turns. Assumption is not ignorance, it's information believed to exist somewhere else. In high-risk systems, that distinction can kill. A checklist is sometimes mocked as bureaucracy added to expert work, but a well-designed verification step does not exist because surgeons forgot that blood type matters. It exists because everyone knows it matters, and that shared knowledge creates the temptation to assume someone else has already checked it. The simplest facts are often the most vulnerable to this diffusion of responsibility. There is a second reason independent checks matter in transplantation. Urgency creates momentum. Donor organs cannot wait indefinitely. Weather had already delayed transport. A recipient had to be admitted, prepared, anesthetized, and opened while teams coordinated across locations. Every hour mattered to organ viability and to Jessica's failing body. Momentum is necessary. It also makes stopping physiologically and operationally difficult. Once the procurement team is traveling and the operating room is active, an unanswered question can begin to feel like a problem somebody must already have resolved. A hard stop exists to resist that momentum. The safest version of a compatibility check is not a note somewhere on a chart. It's a point to the workflow that it cannot cross until the donor result, recipient result, patient identity, organ identity, and responsible people have been matched explicitly. In Jessica's first transplant, the laboratory answer arrived after the workflow had crossed its irreversible point. Jesica remained on intensive support as the search continued. On February 19th, 12 days after the incompatible transplant, clinicians consulted a neurologist and obtained a CT scan of her brain. Duke's chronology says the findings did not indicate irreversible brain damage. That evening, a second heart-lung block became available. This time, the donor organs were compatible with Jessica's blood type. The process was different before the operation began. Duke's transplant coordinator confirmed compatibility with Jaggers and then with the organ procurement coordinator. The procuring surgical team also confirmed organ acceptability and blood group. Duke later said 3 physicians participated in making sure the match was correct. At 5:15 in the morning on February 20th, Jesica was transported to the operating room. At 6 a.m., the second transplant began. At 10:15, surgery was complete. The compatible heart and lungs were functioning acceptably. Jesica returned to intensive care off ECMO, although she remained on mechanical ventilation. The elementary mismatch had finally been corrected. The damage surrounding it had not. At 2 a.m. on February 21st, Jessica's neurologic condition declined rapidly. A CT scan showed bleeding and swelling in her brain. Doctors inserted a catheter to drain fluid and measure intracranial pressure. By 9 a.m., a neurologist found no brain function. Additional testing showed no electrical activity and no blood flow to the brain. On February 22nd, 2 examinations confirmed that Jesica met the criteria for brain death. She was pronounced dead at 1:25 that afternoon. She was 17. It is tempting to compress that outcome into one clean statement: the wrong blood type killed her. The official chronology demands greater care. Jessica's body rejected the first heart and lungs. She required days of intensive immunosuppression, plasmapheresis, ventilation, and ECMO. She then underwent a second major transplant less than 2 weeks after the first. Brain bleeding and swelling appeared after the second operation. Duke described her death as occurring after complications from the incompatible transplant and the rescue attempt that followed. The precise path to the fatal brain injury concluded rejection, critical illness, circulatory support, and repeated surgery. It was not an antibody traveling straight from the first graft into her brain. Accuracy does not soften the error, it reveals its true scale. The first mismatch did not need to be the final direct mechanism of death to transform everything that came after it. It placed a critically ill teenager into 12 days of rescue medicine, forced a second transplant, and consumed whatever margin her body had left. When the laboratory called at 10 p.m. on February 7th, there was no way to rewind to 4:49. That is why prevention in high-risk medicine is built before the operating room, not after the complication. Duke publicly accepted responsibility. The hospital changed its transplant procedures, adding explicit compatibility verification between coordinators and surgeons. Its chief executive said that ultimately Duke's patients were Duke's responsibility even when outside organizations participated in the organ process. That sentence corrected the structural ambiguity. Shared work does not mean shared responsibility can remain undefined. Later in 2003, Duke established a $4 million perpetual fund in Jesica's memory to support Latino pediatric patients and their families. The institution said it hoped lessons from the case would contribute to stronger national transplant guidance. A hospital statement described the fund as support for services surrounding pediatric treatment, not as a price assigned to Jesica's life. Those services could help other families, but none could correct the blood type mismatch itself. Jesica's identity as a Mexican teenager shaped the public conversation around her. It also created a risk that the operational lesson would be buried beneath arguments about citizenship and organ allocation. The hospital's own chronology keeps returning to the concrete chain. An offer was made, a match was assumed, the operation began. The laboratory called after implantation. The useful memorial is not speculation about whether Jesica should have been in that operating room. It's making sure that every patient who reaches one is protected by the verification she did not receive. A memorial fund can help future families. It cannot turn an avoidable death into a fair exchange. Jesica's story also forces a difficult question about how medical systems discuss human error. Calling it human error is accurate but incomplete. A human made an assumption. A safe system should expect humans to make assumptions and place an independent barrier before the assumption reaches a patient. If one forgotten question can pass through procurement, transport, admission, surgery, and implantation without being caught, then the failure belongs to the process as well as the person. Safe systems use independent layers because no individual check is perfect. In Jesica's first transplant, those layers never forced the team to compare the most basic facts. The donor's size, organ function, and cause of death were discussed. The weather delay was managed. An extraordinarily complex operation went forward, and blood type remained an assumption. Complex systems often fail this way. Expertise concentrates attention on the difficult tasks, while a familiar elementary task is trusted to routine. The operation may require years of training, but the prevention step can fit on one line. Donor blood type A, recipient blood type O. Stop. The line existed in the records, it did not exist as an enforced moment in the workflow. After Jesica, Duke made that moment explicit. The second transplant demonstrated what the first process had lacked. The coordinator confirmed with the surgeon, the coordinator confirmed with the procurement organization, the procuring team confirmed again. Compatibility was not treated as background information, it became a spoken owned decision. The change came in time for the second set of organs, it came too late for the first. 3 confirmations may look redundant because they answer the same question. That's the point. When one failure is irreversible, repetition gives an error in one record, conversation, or assumption another chance to be caught. Jesica had crossed borders and waited years for a chance at survival. Her case later became entangled in arguments about immigration, organ scarcity, and who deserved access to transplantation. None of those debates caused the mismatch. The mismatch occurred because a type O patient received type A organs without a completed final verification. Keeping that boundary matters. Systems sometimes protect themselves by allowing a preventable event to dissolve into a larger controversy. The more political and complicated the surrounding story becomes, the easier it is to lose the simple operational failure at its center. Jesica's death does not require embellishment. The record already contains the impossible sentence. Her incompatible heart and lungs were discovered after they had been implanted. Her story changed transplant safety because it made an invisible assumption visible. It showed that the question, who checked, is not the same as the statement, it must have been checked. One asks for evidence, the other asks for trust. In ordinary life, that difference is often harmless. In a heart-lung transplant, it's the difference between a rescue and the need to be rescued from the rescue.